The main immunotherapeutic agents that are being studied now are what's called checkpoint inhibitors, antibodies that bind to either PD-1 or PD-L1. And since they bind to that interaction, one of the biomarkers that's been looked at is PD-L1 expression. And in some cancers, like non-small cell, that's been a decent biomarker. One of the issues in small cell is they tend to have pretty low expression of PD-L1. And therefore, one of the major issues, just like in non-small cell, is there a better biomarker? One of those that's been suggested is tumor mutation burden. And small cell cancers, since they're all in smokers, have a high tumor mutation burden in general. And I'll come back to this, but there's some evidence that tumor mutation burden may be a pretty good biomarker, especially for the addition of anti-CTLA-4 antibodies. But going back to the original studies, there was a study of pembrolizumab alone, and it showed a response rate in about 30% of patients. And the progression-free survival was not real long, but there's a tail on the curve. And the patients who responded, those responses lasted a long time. So there were about 30% of patients who were alive at 1 and 2 years, which is much higher than chemotherapy. So this was in second-line treatment. The response rate, 20–30%, is not outstanding, but the long-term survival was very impressive. There was also a study that was done by Bristol Myers Squibb that had either nivolumab alone or nivolumab plus ipilimumab. And again, somewhere between 20 and 30% of patients responded, which is mostly not related to PD-L1 expression. But the patients with nivolumab plus ipilimumab seemed to do a little bit better, but if they had high TMB, they did much better with the combination.